chemical examination of urine, and it is about proteins. Eta tomra kore escho, you have already done it in biochemistry, so your knowledge about protein will be very good. So what is the normal amount of protein that is excreted in urine per day? What is the normal amount of protein that's excreted in urine per day? Normally কতটা urine excrete হয় urine? কতটা protein excrete হয় urine? How much? What's the amount? It's less than 150 milligram per 24 hours. It is less than 150 milligram per 24 hours. So what are the various proteins that are excreted? Tell me the name of the proteins that are excreted. Settle down. Huh? Tell me the name of the proteins that are excreted. Huh? Ki? Ki? Albumin. Ulto palta kote shuru korchish keno? Start with the commonest one. What is? The first one is albumin. From? Where does it come from? Huh? Plasma. Albumin, the most common. এছাড়া আর কি কি আছে? Tam horsefall protein. Have you heard the name? Tam horsefall protein, নাম শুনেছো? It is secreted from the, these are, other than albumin, which is secreted from the plasma, the rest, like Tam horsefall protein, secretory, IgA, these are all derived from urinary tract. So Tam horsefall protein is also derived from urinary tract. It specifically, which part of the urinary tract? Kidney. Which part of kidney? Ascending limb of loop of Henle. Right. Then you get secretory IgA. And then proteins derived from tubular epithelial cells, desquamated proteins. Sorry, proteins derived from tubular epithelial cells, leukocytes, and desquamated, other desquamated cells. So normally the kidneys excrete up to or less than 150 milligram of proteins per 24 hours, which is generally not detectable by normal routine tests. So when do we use the term proteinuria? Amra proteinuria kokhon boli? When urinary excretion of protein exceeds more than 150 milligram per 24 hours. When urinary excretion of protein exceeds 150 milligram per 24 hours, that's when we use the term proteinuria. Okay. So what are the various types of proteinuria? Ekটু theory bole dicchi, then we will go for practical. So what are the various types of, because heat and acetic acid test, you know how to do it, right? Huh? Korte parbe? You should be able to do it. So you get glomerular proteinuria, tubular, overflow, hemodynamic, and postrenal. There are 5 types of proteinuria. Rather, these are also the causes of proteinuria. Glomerular proteinuria. এগুলো সব থিওরিতে পড়ানো হবে. Everything will be taught in theory. Everything will be taught in theory. Renal এখনো শুরু হয়নি. Renal শুরু হয়েছে কি? Renal শুরু, হ্যাঁ? শুরু. It just started. So these things will be taught to you in theory. Just একটা আমি overview করে দিচ্ছি. Glomerular proteinuria, tubular proteinuria, overflow proteinuria, hemodynamic proteinuria, and post-renal proteinuria. Okay. So coming to glomerular proteinuria, কি করে glomerular proteinuria হয়? The glomerular capillary walls, the basement membranes of the glomerular capillary walls, they become leaky or they become more permeable, and that allows plasma proteins to leak out into the urine. So there is increased permeability of glomerular capillaries, allowing protein to leak out into the urine. So this can be selective and non-selective. This can be selective and non-selective. So what is selective and what is non-selective? Selective means এখানে 50টা স্টুডেন্ট আছে, তার মধ্যে আমি 5 জনকে সিলেক্ট করলাম, 45 কে আমি সিলেক্ট করলাম না. I select out of 50 students in group A, I select 5 and I reject 45. So that is called selection. সবাইকে আমি সিলেক্ট করতে পারবো না. So urinary excretion, secretory proteinuria তে কি হচ্ছে, selective proteinuria তে কি হচ্ছে, there is excretion of lower molecular weight proteins like albumin and transferrin. There is excretion of lower molecular weight proteins like albumin and transferrin, whereas the higher molecular weight proteins like gamma globulins, they are not secreted. Okay, so that is selective proteinuria. The lower molecular weight proteins like albumin and transferrin, they are excreted, but the higher molecular weight proteins are not. That is why it's selective, seen in early stages of glomerular diseases. But as the disease progresses, the selective proteinuria slowly but steadily converts, changes, switches over to non-selective proteinuria. That's when higher molecular weight proteins are also like gamma globulins, along with albumin transferrin, the higher molecular weight proteins are also excreted in urine. That is called non-selective proteinuria. The selectivity is lost. Correct? So, in selective proteinuria, ki paccho tomra? Only low molecular weight proteins like albumin and transferrin are excreted, whereas in non-selective proteinuria, along with lower molecular weight proteins, higher molecular weight proteins like gamma globulins are also excreted in urine. So, the selectivity is lost. So, selective proteinuria occurs in early stages of glomerular diseases, whereas non-selective proteinuria occurs in late stages of glomerular diseases. Okay. What are the various glomerular diseases which causes proteinuria? What are the various glomerular diseases which causes proteinuria? So, primary glomerular diseases, secondary glomerular diseases and others. So, primary includes all pathology lies in the glomerulus. So, it can be minimal change disease, idiopathic membranous glomerulonephritis. What is FSGS? Focal segmental glomerulosclerosis, MPGN, membranoproliferative glomerulonephritis, and then IgA nephropathy. Right? So, this is the primary glomerular diseases. Which are the secondary glomerular diseases? Which are the secondary glomerular diseases? So, these are the primary. Karon egulo, the pathology lies in the kidney only, in the glomerulus. Minimal change disease, IgA nephropathy, focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis, then idiopathic membranous glomerulonephritis. Here the pathology lies in the glomerulus itself. So, it is primary glomerular disease. Then comes secondary glomerular disease. Secondary, mane the primary pathology do not lie in the glomerulus. So, which diseases can give rise to this? SLE, systemic lupus erythematosus, DN, diabetic nephropathy, end stage kidney disease, HTN, hypertension, various hypertension, okay. Then comes others like systemic diseases, infections, various medications, heavy exercise, fever, stress, they can all give rise to glomerular proteinuria, okay. Coming to tubular proteinuria. Tubular proteinuria te ki hocche? In diseases involving the renal tubules. Agei bolechi, ager class I have explained. Glomerulus theke jeta filtered hoy, tar moddhe theke maximum is reabsorbed by the proximal convoluted tubules. Right? So, technically, there should not be any excretion. Now, in tubular proteinuria, the glomerulus is maybe filtering well, but tubule theke reabsorb hocche na. So, here the pathology lies in the maybe the proximal convoluted tubules. So, the pathology lies in the tubules. So, ekhane ki hoy tubular proteinuria te very low molecular weight proteins, very low molecular weight proteins also, other than albumin and transferrin, tar cheyo low probably beta 2 microglobulin, alpha 1 microglobulin, then lysozymes, RBP. What is RBP? Retinol binding protein. Retinol binding protein, free immunoglobulin light chain, they are all excreted. They are all excreted. And here the pathology lies in the renal tubules. The pathology here lies in the renal tubules. So, tubular pathology. So, what can be the causes? What can be the causes? acute and chronic pyelonephritis. Tubules, right? So acute and chronic pyelonephritis, tuberculosis of kidney, heavy metal poisoning, interstitial nephritis, cystinosis, Fanconi syndrome, rejection of kidney transplant, কয়েকটা মনে রাখলেই হবে, acute and chronic pyelonephritis. So renal tubules ke involved হচ্ছে এখানে, the renal tubules are involved. So the causes are acute and chronic pyelonephritis, interstitial nephritis, then cystinosis, Fanconi syndrome, rejection of kidney transplant, heavy metal poisoning. So these are the ones where the renal tubules are affected. So that is why the protein excreted because of this is known as tubular proteinuria. Tubular proteinuria. So you get glomerular proteinuria. Now you have tubular proteinuria. ভাই এসিটা চলছে না নাকি? চলছে? Then you get overflow proteinuria. What is overflow proteinuria? Overflow proteinuria ta ki? When concentration of low molecular weight proteins rises in the plasma, it overflows in the urine. When concentration of low molecular weight proteins rises in the plasma, concentration বেড়ে যাচ্ছে, the plasma can't hold it anymore. So it overflows in urine. So that is known as overflow proteinuria. Most common কোনগুলো? Benz-Jones proteins. Benz-Jones proteins. What is Benz-Jones protein? Huh? So what is it? It's immunoglobulin light chain, kappa or lambda, right? কোথায় দেখা যায়? What kind of chain it is? Light chain. ওটা কি রকম? Neoplastic, non-neoplastic? Neoplastic. So it's monoclonal. Monoclonal immunoglobulin light chains of either kappa or lambda variant. কোথায় পাওয়া যায়? Seen in plasma cell dyscrasia. Don't say multiple myeloma straight away, fine, good enough. So plasma cell dyscrasias. So plasma cell dyscrasias অনেকগুলো হয়, তার মধ্যে most common is multiple myeloma. Multiple myeloma is the most common plasma cell dyscrasia. So Benz-Jones protein একটা গেল. Other than that there is hemoglobin. Hemoglobin কোথায় কোন কন্ডিশনে hemoglobin যেতে পারে? In case of in case of hematuria তো ঠিক আছে, that condition is hematuria. UTI, acha, intravascular hemolysis. Then you get myoglobin. Myoglobin skeletal muscle trauma is the most common. Then lysozyme, acute myeloid leukemia, M4, M5A. So this is basically overflow proteinuria. Overflow proteinuria occurs when does overflow proteinuria occur? When the concentration of low molecular weight proteins rises in the plasma, that it overflows from the plasma into the urine. So which proteins are involved? Benz-Jones protein seen in plasma cell dyscrasia. So most common plasma cell dyscrasia is multiple myeloma. Then you get hemoglobin seen in intravascular hemolysis, myoglobin in skeletal muscle trauma, and lysozyme in AML, M4 or M5. Okay, clear? Then you get postural proteinuria. Postural proteinuria, অনেকগুলো proteinuria আছে, নামগুলো মনে রাখতে হবে. Postural proteinuria. Postural proteinuria কখন হয়? Because of altered vascular flow or altered blood flow through the glomeruli. Because of altered blood flow through the glomeruli resulting in increased filtration of proteins. Because of altered blood flow through the glomeruli resulting in increased filtration of protein. Seen in, it's a very transient phenomenon. Okay, it does not stay. It's a very transient phenomenon, and with inhibition of the causative agent, the proteinuria disappears. And proteinuria is very mild, say probably less than 1000 milligram per week. Sprinkle some water. You need to Sure. So, high fever, heavy exercise, hypertension, congestive cardiac failure, seizures, exposure to cold, this all results in altered blood flow through the glomeruli, resulting in increased filtration of proteins. Resulting in increased filtration of proteins. So, there is something called postural proteinuria. Postural proteinuria, which is seen in standing position, but you don't see any proteinuria in recumbent position. So, postural proteinuria is the one which you see mostly in case of in standing position, but not in recumbent position. Proteinuria is very less, and proteinuria disappears also. It's very transient. And then there is a posture called lordotic posture. What is a lordotic posture? Lordotic posture, something like this. There is flexion of the spine and all. I'm not very sure. Anatomy poresto tumra, so you should be telling. So in lordotic posture, basically there is inferior vena cava compression between the spinal cord, with the liver and the spinal cord. In lordotic posture, there is এরকম একটা position. In lordotic posture, excessive bending হলো এরকম তো. So basically what happens in lordotic posture is there is inferior vena cava compression between the liver and the spinal cord, resulting in increased proteinuria. Okay, so this is postural proteinuria because of the posture, mostly seen in standing position but not in recumbent position. And lordotic proteinuria, lordotic position is the one, if you mention it's fine. Okay, it's going to get you extra brownie points, that's all. And then post-renal proteinuria. Post-renal proteinuria means after the kidney. The pathology lies at a point which is away from the kidney, which is after the kidney. So where does the pathology lie? Say probably bladder, ureter, urethra, etc., etc. Okay, and it occurs because of inflammation or neoplasms in these sites. So that is post-renal proteinuria. So what are the various types of proteinuria? Glomerular, tubular, then overflow. Overflow part ke hemodynamic, and then postrenal. So proteinuria, how do we get? Grade proteinuria: mild, moderate and severe. Less than 1500 milligram is mild proteinuria. Various causes ami ar jacchi na. Moderate 1500 to 3000 milligram per 3000 milligram per 24 hours, that is moderate proteinuria. And more than 3500 টাকে কি বলে? nephrotic range proteinuria. nephrotic syndrome এ পাওয়া যায়. Okay, more than 1500 milligram per 24 hours or more than 3.5 grams per 24 hours, however you want to say it, it's all the same, milligram or grams. Okay, so that is nephrotic range proteinuria. Correct? So this is how you grade proteinuria: mild, moderate, severe. So what are the tests used for detection of protein? So again, there is one qualitative test or semi-quantitative test, and there is a quantitative test. So qualitative test যেটা আমরা করব আজকে, heat and acetic acid test. Heat and acetic acid test. Then we do the reagent strip test and sulfosalicylic acid test. Heat and acetic acid test, reagent strip test and sulfosalicylic acid test. So reagent strip, heat and acetic acid test predominantly is for albumin. Reagent strip test is also predominantly for albumin. So other proteins like Benz-Jones protein, hemoglobin, myoglobin, immunoglobulin light chains, they can be missed if we do only these two tests. So which is the confirmatory test? The last one, sulfosalicylic acid test. The sulfosalicylic acid test is the one which is confirmatory, and this is the one which identifies all forms of protein. So these two tests must be confirmed by sulfosalicylic acid test. Okay, then you get the quantitative detection of protein. So quantitative methods include quantitative estimation of protein in a 24-hour urine sample. Quantitative estimation of protein in a 24-hour urine sample. Very cumbersome to do it. Okay, so which methods we do? Esbach's albuminometer method, turbidimetric methods, biuret reaction, and immunologic methods. Just remember the name. Excuse me. And then you have one more, estimation of protein bar creatinine ratio, estimation of protein bar creatinine ratio in a random urine sample. Just remember the name, estimation of protein creatinine ratio in a random urine sample. So যদি জিজ্ঞেস করে কি method, do not just say heat and acetic acid. Say qualitative estimation and quantitative estimation. Qualitative estimation e ki pore, quantitative estimation e ki pore. Just know the names, okay? So heat and acetic acid test. So what is the principle of heat and acetic acid test? What is the principle of heat and acetic acid test? Denaturation of proteins, right? Huh? ডিম সেদ্ধ করলে কি হয়? নরমাল ডিমটা কি রকম থাকে? ভেতরে একটা ইয়েলো yolk আর সাদা অ্যালবুমিন. So when you boil it, কি হয়? It forms a flocculum. Why? Because albumin gets precipitated on heating. So similar principle applies to urine also. Okay. So protein precipitated on heating. Protein is precipitated on heating. Okay. So what is the procedure? What is the procedure? You have to take 2/3 or 3/4 of the test tube with urine. Then what you have to do? You have to heat the upper part. You have to heat the upper part. If turbidity appears, it may be either because of protein or because of phosphate. So how do you differentiate between the two? You add 10% acetic acid. You add 10% acetic acid. If precipitate disappears, it is because of phosphate. If the precipitate persists, it is because of protein. Okay. Then reboil the specimen and take the result. Reboil the specimen and take the result. Now, before you do heat and acetic acid test, you must remember certain things. A few points must be remembered. Urine should be clear. If the urine is not clear, either filter the urine or centrifuge the urine and use the supernatant for chemical examination and use the sediment for microscopic examination. Because turbid urine অনেক কারণে হতে পারে. Turbid urine can be because of inflammation, it can be because of infection, it can be because of some neoplasm, there can be phosphates, there can be so many reasons for a turbid urine. Okay, so you have to do a microscopic examination in that case. So, filter the urine or centrifuge the urine, use the supernatant for chemical examination, and the sediment, jeta niche pore ache, the sediment will be used for microscopic examination. Okay, if the urine is acidic, if the urine is alkaline, or if the urine is alkaline, it should be made acidic. Ki kore korbe? By adding 10% acetic acid drop by drop. So initially, you have to use a litmus paper. You have to use এগুলো আমরা করব না ঠিকই, কিন্তু আমি জাস্ট এগুলো জিনিসগুলো জেনে রাখো. You have to use a litmus paper. Check with the litmus paper. The blue litmus paper in an alkaline urine will turn red if the urine is acidic. এগুলো বেসিক, এগুলো আমি এক্সপ্লেইন করছি না. Blue litmus paper will turn red if the urine is acidic. If the urine is not acidic, add 10% glacial acetic acid drop by drop till the urine becomes acidic. And how do you know that the urine has become acidic? The blue litmus paper will turn red. Right? So এই points গুলো কিন্তু মাথায় রাখতে হবে. Now my question is, okay, আমি ইন্টারপ্রিটেশনে আসছি. আচ্ছা, ইন্টারপ্রিটেশনটা একবারে করে দিই. No turbidity means protein absent. No turbidity means protein is absent. No turbidity means protein absent. ঠিক আছে? Cloudiness now visible against a dark background. Slight faint cloudiness or cloudiness just visible against a dark background. Trace protein. প্রোটিনের ট্রেস খুব আছে, এইভাবে দেখতে হয় এইভাবে। Cloudiness without granularity 1 plus, cloudiness without granularity 1 plus, cloudiness with granularity, cloudiness with granularity 2 plus, right? Precipitation and flocculation is 3 plus, precipitation and flocculation is 3 plus, and thick solid precipitation is 4 plus. Thick solid precipitation is 4 plus. So how do you interpret? No turbidity, protein absent. Now cloudiness, slight cloudiness which is just visible against a dark background, trace protein. Cloudiness without granularity 1 plus, cloudiness with granularity 2 plus, precipitation and flocculation is 3 plus, and thick solid precipitation means 4 plus protein. Okay? Now question is, why the upper portion is heated? Why the upper portion of the urine is heated and not the lower portion? Because the convection current that is generated, the convection current generated due to heat do not disturb the precipitate. Basically, you can use the lower part as a control. Basically, the lower part of the urine can be your নাম কি রে শুনছিস কি বলছি বলতো লোয়ার কি লোয়ার কি মানে শুনছিস না যা জল দিয়ে যা মুখে জল দিয়ে হাই তুলছি এক্ষুনি আমি দেখেছি জল দিয়ে দিবি না so convection current generated because of the heat do not disturb the precipitate, and also the upper portion can be compared with the lower portion. The lower portion acts as a control. Heat and acetic acid test মনে আছে কিভাবে নিচটায় কিছু আসে আসে না উপরটাতেই যা আসার আসে রাইট হ্যাঁ উপরটাই টার্বিডিটি নিচটায় আসে না এক্স্যাক্টলি এই জন্য আদার টেস্ট আমি অলরেডি মেনশন করেছি reagent strip test which detects mainly albumin, and sulfosalicylic acid test, almost all proteins are detected, and this is by far the most sensitive test. Okay. So this is a basic comparison, ami ar jacchi na. This is a basic comparison between reagent strip test and sulfosalicylic acid test. If you need just etai bolchi last dekho type of test, reagent strip test is screening, whereas sulfosalicylic acid test is confirmatory. So even though we are going to do heat and acetic acid test, if question is asked, if the examiner asks you what is the confirmatory test for detection of proteins, qualitative confirmatory test, your answer will be sulfosalicylic acid test. Then comes quantitative estimation of protein. Amra keno, what are the indications for quantitative estimation of protein? One is detection of nephrotic syndrome, two, detection of microalbuminuria, or early diabetic nephropathy, and to follow response to therapy in renal diseases. How do you grade albuminuria? Again, normal is less than 30 milligram per 24 hours. Microalbuminuria is 30 to 200 milligram per 24 hours. That range, 30 to 200 milligram per 24 hours, is microalbuminuria. 30 to 200 milligram per 24 hours, that range is microalbuminuria. And overt albuminuria is more than 300 milligram per 24 hours. More than 300 milligram per 24 hours. Okay. So what is microalbuminuria? I think this is the last one. Yeah. Microalbuminuria importance ta ki? This is more of theory. Microalbuminuria is the earliest sign of diabetes, renal damage in diabetes mellitus. Mane albumin is getting excreted in the urine. So this basically means in a patient of diabetes mellitus, this is the earliest manifestation of renal damage in a case of diabetes mellitus. Okay, and this also proves that this patient will have overt, basically same thing. If A equal to B and B equal to C, A equal to C, basic geometry. So এখানে the third line indicates the same thing. It precedes the development of diabetic nephropathy by a few years. মানে পেশেন্টের মধ্যে যদি এই জিনিসটা পাওয়া যায়, it indicates that in a few years, if measures are not taken, they will proceed to overt diabetic nephropathy. Their kidney damage is inevitable. And it is also an independent risk factor for diabetes mellitus, an independent risk factor for diabetes mellitus. And how do you measure a microalbuminuria? Measurement of albumin-to-creatinine ratio in a random urine sample, measurement of AC ratio in a random urine sample, measurement of albumin in an early morning or random urine sample, and measurement of albumin in 24-hour urine sample. জানতে হবে না এতটা, just আমি দিয়ে দিলাম. Okay? Have you taken 2/3? So, she has taken 2/3 of the urine in a test tube. Means it's 2/3 filled or 3/4 filled. Half fill করলে হবে না, less than that না, up to 2/3 or 3/4 of the urine has been filled with urine. Right? এই ওখানে দেখতে পাচ্ছিস? Okay? Next step. So আমি এখানে ওকে 1 মার্কস দিয়ে দিলাম পুরো. Next. Note the transparency of the urine. Transparent না opaque? এখানে দেখে ট্রান্সপারেন্ট আছে, ঠিক আছে? নেক্সট স্টেপ করো। এখানে ইনকোয়ারিং অ্যাবাউট দ্য পিএইচ অফ দ্য ইউরিন, এখানে লিটমাস পেপার নেই, সো ইউ ডোন্ট হ্যাভ টু ওয়ারি। নাও এবার হিটিংটা আসছে ওইভাবে। টেস্ট টিউব একটা হোল্ডার দেবে না? না করেছে, আচ্ছা ঠিক আছে। অবশ্য নিচ তো দেখি এরা কি লিখেছে কিনা। কিরে আসছে? So what are you going to do now? Adding acetic acid drop by drop. মমিতা, অ্যাসিটিক অ্যাসিডটা কোথায়? কোথায় রে? না ওটা বেনেডিক্টস। ওইটা হ্যাঁ অ্যাসিটিক অ্যাসিড, হ্যাঁ এটা আমি আমার ল্যাব থেকে বানিয়ে নিয়ে এসেছি। হ্যাঁ এখানে আসেনি এখনো অ্যাসিটিক অ্যাসিড, সেটা আমি নিজে বানিয়ে নিয়ে এসেছি। এটা একটা ড্রপার দে মমিতা। Is it easy or tough? যেভাবে খুশি করলে হবে না, সবাই তো দেখো ভাই গ্লেশিয়াল অ্যাসিটিক অ্যাসিড যে কেউ করে দিতে পারবে, কিন্তু তোমরা অ্যাজ আ মেডিকেল স্টুডেন্ট তোমরা কি প্রত্যেকটা স্টেপ ফলো করছো কিনা সেটা আমায় দেখতে হবে, তাই না? কত ড্রপ? ফিউ ড্রপস, ওই তো। একদম মিক্স করে দিও না, টাচ করে দিও না, উপর থেকে দাও। ঠিক আছে চলো রেখে দাও, এটা প্যাকেট এখানে রেখে দাও, ছেড়ে দাও, হ্যাঁ সাইডে রাখো। প্রেসিপিটেট টার্বিডিটি আছে না নেই? টার্বিডিটি এক্সিস্ট, তার মানে সো দিস ইজ নট ফসফেট, রাইট? কারেক্ট? টার্বিডিটি যদি ডিসঅ্যাপিয়ার করে যায়, ইট ইজ মেইনলি বিকজ অফ ফসফেটস। সো টার্বিডিটি পারসিস্টস, which means it is not because of phosphate. Then follow the next step. Reboil koro, keep boiling, একটু boil করো। নিচে চলে যাচ্ছে তোমার, উপরে করো। ঠিক আছে। কত প্রোটিন? এটা কত প্লাস দেওয়া যাবে? 4 প্লাস কি হবে? 3 প্লাস হবে। 4 প্লাস ফ্লকুলামস, দেখ থিক সলিড প্রেসিপিটেট কি হয়েছে?